Well, welcome everyone, and thanks for joining us to discuss this subject of hypersexuality, which is a prominent feature of bipolar, but not talked about anything like enough. I'm Clare Dolman, and I've lived with bipolar since my teens, so this symptom of the condition is something that certainly impacted my life in the 7 years before I got a diagnosis and started taking lithium. And I'm just going to share my slides. Here we go. Okay. Great. So as you can see, today's webinar has been funded by the Hypatia Foundation as part of our Women and Bipolar series. And we're very glad to be presenting it in collaboration with the National Centre for Mental Health in Wales and the East Kent Rape Crisis Centre. And as we'll be covering topics that may be upsetting, including rape and sexual assault, we won't be using the chat function, though we will hopefully get to some of your questions at the end. But if you need support, the Bipolar UK support team are available to speak to you. So do email to book a call. And you can also see on this slide the rape crisis helpline numbers. So do take a screenshot if you want to speak to someone after this webinar or when you feel able to. And the people answering your call won't judge you. They understand the condition and they're there to help. And this is the second webinar that we're doing about hypersexuality, and you can find the first one on our website under Webinars Bipolar Symptoms, which is on the Digital Resources tab. And here's the link which Molly will put in the tab as well, in the chat as well. That webinar addressed how this symptom affects both men and women. But today we're focusing primarily on how this symptom affects women. And this is partly because, as I said, this webinar is sponsored by Hypatia, and so it's part of their support specifically for women with bipolar, but also because our surveys and feedback on this subject have provoked the greatest response from women. And I first asked about this issue in the Bipolar Commission's survey on women and bipolar, and we were shocked by the massive response and the amount of damage psychologically and to relationships and careers that it had caused. Many women spoke of the trauma that they were suffering as a result of finding themselves in dangerous situations that ended in sexual assault or rape, of having to cope with unwanted pregnancies and terminations. And they also spoke of suffering years of crippling guilt and shame at the totally out of character way that they behaved and the resulting awful consequences. So the full survey that we then conducted on hypersexuality confirmed the extent of the harm done by this symptom. And although many men told us of the damage that it had wrought in their lives and how it would be helpful for them to be able to talk more openly about it, we were also very concerned at the large number of women who had been deeply traumatized by what had happened to them while suffering this symptom and who had received no counselling or other help to cope with it. So this webinar, we hope, is a first step to try to address that need. And we've brought together a great group of people, and in particular, we're very grateful to Anne for being willing to share her personal experience, and to Zoe from the Rape Crisis Centre, who is going to talk about the support available for people with bipolar in her service. So firstly, just to give you some background, here's a definition of hypersexuality: an unusual or excessive concern with or participation in sexual activity. We don't know why this happens to us, those of us with bipolar, as there hasn't been enough research on it to find out. But our survey was the first investigation of its kind to record the views of a considerable number of people with bipolar on this subject. We had over 1,650 people with bipolar respond, and 2/3 of those were women. And of those, 88% said they had had episodes of hypersexuality. Nearly half said they had had 8 episodes or more, and almost all had occurred during mania or hypomania. And it's worth saying here that this was not just related to those of us who have bipolar 1, because 92% of respondents with bipolar 2 also reported this symptom. And perhaps the most shocking results from the survey emerged from the questions about how this symptom had impacted respondents' lives. So more than a third, 35% of people in total, had been sexually assaulted as a result, though many more women than men reported this happening, 42% as opposed to 15% for men. And the other results for women are similarly distressing. 27% had been raped, 20% had had an unplanned pregnancy, and 25% had contracted an infection. And when we asked people to tell us more about their own experiences, hundreds responded with shocking accounts of traumatic incidents, and they spoke of being very reckless and totally fixated on sex day and night. Quote, "I did things that I'm ashamed of and would never do normally." Another reported that when gripped by hypersexuality, quote, "sex feels like an addiction and rational thinking disappears." There were numerous accounts of feeling compelled to search out sexual gratification, leading to dangerous situations that caused people harm physically and psychologically. For example, quote, "I was going out drinking unsafe amounts of alcohol every weekend, meeting people online and then sleeping with them, putting myself in dangerous situations, blackouts, waking up in strange places. Also during this time, I contracted chlamydia." It's important to realise that with an average time to receive a diagnosis of nearly 10 years, most people suffered this symptom for years without any understanding of what was happening to them, and mostly during their late teens and early 20s, so at a very vulnerable time. Many, including me, agonised over why they behaved in such a risky way and berated ourselves for selfishly hurting those around us. We had no idea that our behaviour was a recognised symptom of the mental illness that we were suffering. And this is borne out by the answers to a survey question on when people became aware that hypersexual behaviour was a symptom of bipolar. 81% only found out after diagnosis. Over half of those a long time after. So we hope that by holding webinars like this and calling for more research on the subject, we're helping to raise awareness so that in future, people will know this could be a symptom of bipolar and they won't beat themselves up so much about behaviour linked to a mental health condition that isn't their fault. Here you can see a snapshot of how that lack of knowledge breeds massive guilt and shame. Looking back, half of respondents felt self-disgust, 60% ashamed, and 55% felt guilty. Tellingly, 22% said they would never come to terms with their behaviour, and nearly half dread their mood changing in case they behave that way again. And as you can see here, almost half of our survey respondents said they had never discussed this subject with anyone. So they continue to live with those destructive feelings of guilt and shame without any treatment or help. And such feelings can have a terrible impact. Nearly 2/3 of people had suicidal thoughts as a result of hypersexuality, and 20% said that they had attempted suicide because of it. And this is also why it's so important to raise awareness among health professionals, from psychiatrists and mental health nurses to psychologists, therapists, and GPs. Because as you can see here, 60% of our respondents had never been asked about hypersexuality by a professional and how it had affected them. Anecdotally, too many professionals are embarrassed or find discussing the subject awkward, or they've had no training on A, how to talk about it, and B, how to help. I'm hoping that we'll gain some insight into the attitude of professionals to this subject and what can be done by hearing from our first guest. So I'll just stop sharing my screen. Okay. So we're going to turn to you, Arianna. Professor Arianna Di Florio, to introduce her properly, is a researcher and consultant psychiatrist who spent most of her career researching mood disorders, especially bipolar, and she's currently leading the reproductive mental health clinical research programme at Cardiff and is one of the few researchers in the UK specialising in how these conditions affect women in particular. So we're very grateful to collaborate with the National Centre for Mental Health on this webinar and to invite her to give us the benefit of her knowledge and experience. Over to you, Arianna.
Thank you, Claire. Good afternoon. Can you see my screen, the presentation?
Yeah.
Brilliant. So I'll start with acknowledgement, actually. Claire has been the beating heart of the work I'm presenting today, and I'm really, really grateful. Jasmine Reeve Foster is a Cardiff University medical student, has been working with Claire and myself on the data that Claire and Bipolar UK have collected. The Bipolar Disorder Research Network team for providing expertise and access to the largest clinical cohort of people with bipolar disorder in the world. I'm going to present some data on BDRN today. Most of all, I'm grateful to all participants to our studies and the Bipolar UK survey who have informed the results I'm going to present. Our program is funded in Cardiff by the Medical Research Council, by the European Research Council, and we've organized during the past winter some webinars on women's mental health with the idea of giving back to participants who so generously have volunteered their time and their experiences. So really, this is thanks to them and for them. Thank you. From a clinical perspective, there are no clear definitions of hypersexual behavior. The diagnostic manuals don't even identify hypersexual behavior as a separate criterion for mania in bipolar disorder. The World Health Organization explicitly mentions hypersexual behavior only in the diagnostic criteria of hypomania, but not mania. Poor definitions translate into inconsistent findings and lack of clinical best practices. The prevalence of hypersexual behavior in bipolar disorder varies widely from 25 to 80%, depending on the study. It is also unclear whether hypersexual behavior is always dependent on mood, so if it happens only during mania or during depression, or if it can also occur independently outside mood episodes, and if this is the case, what's its clinical significance? Moreover, as Claire mentioned, sexuality is an extremely personal matter. Many people might not want to disclose sexual behaviors and experiences with their treating team, especially outside a trusted relationship. And this is up to the clinician, of course, to build a trusted relationship. Similarly, they might not engage in research on this topic, increasing the risk of participation bias. We try to address some of these limitations by using multiple lines of inquiries. Claire has already presented the Bipolar UK survey, and in parallel, we run also some analysis again on the BDRN large cohort. On the Bipolar UK survey, I'll just focus briefly on experiences reported by people, because I think this is key to build a clinical assessment that is actually based on patients' experiences rather than on what clinicians think. As you can see from this graph generated by Jasmine, there is a range of behaviors, and these behaviors show very different patterns in men and women. Here, I want to stress that these behaviors are per se not pathological. Here, we need to be very, very careful and avoid thinking in normative terms. Rather, we should focus on relative changes from usual behaviors and on consequences, as Claire mentioned. Clinicians' focus should be on behaviors that have a change from usual and that can cause significant distress or harm, rather than a deviation from preconceived norms. As surveys are affected by participation bias, we also run a quantitative study, which I believe is the largest on the topic to date, including over 3,500 people with bipolar disorder. Participants were asked about increased sexual interest and or activity in the worst episode of bipolar disorder. Please be aware that the results include content that people might find triggering, so just step away for a minute if that's the case. The prevalence of hypersexual behavior in this cohort was about three quarters, sorry. There were no differences between males and females, present or absence of psychosis, marital history. People who disclosed hypersexual behavior were more likely to report an earlier onset of bipolar disorder and a higher scores of questionnaires that investigated personality. They were also more likely to report being victims of childhood sexual abuse. As this is quite concerning, I want to dive in a bit more detail here. And if you're looking at proportions, here in Black people with history of hypersexual behavior, and in pink those without, we see that although there is a significant difference here, I don't know if you can see my mouse, this is the top two bars, there is a significant difference. However, history of childhood sexual abuse is still something that affects only a minority of participants, but we need to be aware of this if we want to help people in clinic. So to conclude, there is a need for consistent and objective definitions of hypersexual behavior in bipolar disorder, not based on evaluative standards, okay? So not talking about what's normal here, but being patient-centered. So we need to contextualize this in the history of the person. While the prevalence in men and women, I think it's similar, the behaviors and their impact are very different. And Claire mentioned the impact on women, which is really, really shocking. Especially it's very shocking if we think this is an absolutely, usually neglected topic. We rightly tend to worry about traumatic consequences of hypersexual behavior, but I think our research might suggest actually a possible link with childhood trauma and more complex clinical pictures that should also then be investigated. Also, like going forward, but also looking back, I think might be important for patients with this issue. The most important thing is really clinically is trust. Continuity of care. Of course, you can't see a different doctor every time and expect to disclose so painful personal details, and also multidisciplinary approaches. I think we should start to think about including hypersexual behaviors in the training of healthcare professionals, both ways, both coming from a psychiatric perspective, so working with people with bipolar disorder, but also healthcare professionals that see people with STIs or like with other issues that might be come in contact with people with bipolar disorders that way. And definitely we need to engage and involve patient support organizations, because the role here has been really, at the moment, they're doing the work we should all be doing. So really important to have them involved as well. Thank you.
Thanks, Arianna. That's really interesting stuff. Now we're going to move to Daisy, and Daisy Harvey is a researcher and she's a PhD student at Lancaster University, and she's going to talk about her research on the language of risk-taking related to hypersexuality. So over to you, Daisy.
Hi. Oh, thanks, Molly. Okay, well, hi everyone. Thanks for the introduction, Claire, and I'm really happy to be here today to talk about such an important topic. So I'm in the final year of my PhD at Lancaster University, and my research is looking at the language of risk-taking in bipolar. So through my first study, I had the opportunity to interview both individuals with a diagnosis of bipolar and also healthcare professionals who have expertise in this area. And today I'll be sharing just some of the key insights from these interviews, and specifically looking at the experiences of hypersexuality, which were reported by some of the women that I spoke with. Can I have the next slide, please? Thank you. So the interview study aimed to really investigate risk-taking from a lived experience lens. So participants defined risk-taking as engaging in behaviours which were beyond the norm or which were potentially hazardous. And while risk-taking isn't exclusive to bipolar, obviously, there is research that does suggest that individuals with bipolar might be more likely to engage in risky behaviours. This could be due to emotional and biological factors, but it highlights the need for robust support structures. So hypersexuality emerged as a significant theme during the interviews, and 64% of female participants described it as a risk-taking behaviour. Some examples of the types of hypersexuality that were discussed during the interviews included things like using dating apps to meet with strangers, having extramarital affairs, having unprotected sex, and sometimes experiencing changes in sexual orientation during an elevated mood state. And more than half of the women who reported hypersexuality also described feelings of guilt and shame. And some of the women reported that they were actually disclosing these experiences for the first time. And that really underscores the pressing need for increased awareness and also enhanced service provision in this area. Next slide, please. So when we analysed the data, we found that all of the female participants who reported hypersexuality associated it with being in an elevated mood. So that was either hypomania or mania, and also rapid cycling. Some participants voiced challenges in accessing psychological treatment, and also noted that there was generally a lack of psychosocial support available as part of their treatment for bipolar. Some of the people we interviewed reported that discussions around risk-taking behaviours like hypersexuality are notably absent in healthcare consultations, and conversations around risk tend to focus more on factors like suicide and self-harm. And as has already been said, this aligns with existing research, which suggests that healthcare providers might avoid broaching sensitive topics like sex and hypersexuality because they feel uncomfortable or because they're relying on people to self-report these symptoms. And as we know, that presents a significant issue because people living with bipolar might not always recognise that hypersexuality is a symptom, or they might not feel comfortable discussing it in a clinical setting. And added to this complexity, some of the women in the interviews expressed apprehension about disclosing sexual behaviours to healthcare providers because they were scared of being misunderstood. And just to briefly talk, so aside from the limited discourse around this topic with healthcare professionals, the women that we talked to also highlighted serious impacts which stemmed from hypersexuality. So that included things like unplanned pregnancy, concerns about contracting sexually transmitted infections, jeopardizing relationships, and instances of vulnerability leading to potential harm from other people. Next slide, please. So finally, moving on to what improved support could look like. Interview participants overwhelmingly described that they wanted better access to psychological therapy, as well as more advice about risk management strategies, regular meetings with someone like a community psychiatric nurse, and also that people wanted more symptom-specific solutions rather than focusing predominantly on medicinal treatment, especially for symptoms like hypersexuality. And it's equally important that we try and normalise discussions around sex and hypersexuality, and that means fostering greater awareness of hypersexual behaviour and ensuring that there's the availability of relevant support and educational resources. So several participants actually recounted negative encounters with healthcare providers, and that was characterized by the use of stigmatizing or shaming language. And as a result of this, some of the women expressed a preference for disclosing sensitive information to female clinicians. So it's really vital that people feel empowered to make informed decisions regarding their clinical team, and that means there needs to be a focus on enhancing diversity within healthcare provision, and particularly within the field of psychiatry. I think that's about all I have time to cover. So I'm really happy to have been involved in the discussion, and I'd like to say thanks to all of the wonderful participants who took part in the study. And I'll hand back over to you, Claire. Thank you.
Thanks very much, Daisy. That was really interesting results you got there. And it shows there's so many important aspects to this subject which need investigating. So now I'd like to introduce Anne Chataigné, who is French but lives and works here in the UK. And Anne has made a wonderful film, a documentary film called Trust Me, about what happened to her on her way to getting a bipolar diagnosis, and she's going to tell us a bit about that and also about her own experience. So over to you, Anne. Thanks very much for being with us.
Thanks, Claire. I just want to check if you can hear me okay, and if my connection is okay.
It's good.
Perfect. All right. So my name is Anne Chataigné. I think I'll start by saying that this is a personal account, so not everyone will recognize themselves in exactly what I'm saying, but I hope that what I will share might help other people who are going through it or who have gone through it. So as Claire mentioned, I have made a film. This is not my day job. I've got fantastic friends whose job it is. And so my friend Melanie Couradabal and Suvitata. Melanie is the director and co-writer with me, who is also the protagonist. And they came up to me and they said that it would be wonderful to make a film about my story. So to that I replied that it was great if Melanie could do my eulogy. And, you know, I was just a little bit stunned by having a documentary about me in the first place. But then we had more conversations. We realized that actually we wanted to tell a story without describing life in a day of someone who has bipolar, but instead trying to make people identify with what it feels like. So we used animation as one technique, and the other one, which is film. And so we blended the two, and that allowed for me to be protected as well, my identity. So a lot of the film, I'm animated, and it also allows for better identification of someone with the main character. And so we were in the script writing, trying to think about what to cover for it, and we decided not to go chronologically, but include themes. We also focus specifically on the mania. And the reason why is because I felt the most stigma towards that side of the illness. Depression, I thought, was a little bit better understood. It depends on everyone, but for me, really, I thought bipolar was, you know, mania and bipolar was the crazy kind, and I just really wanted to dig into that. There was also a big question about whether to talk about hypersexuality, because as it was mentioned by a few people already on this webinar, I really identify with how much I didn't know about hypersexuality even after having had the diagnosis. So it really came to the fore only 5 or 6 years after. And then when we started making the film, we had interesting conversations as to what to include, what not to include, conversations with people who had been there, because the illness doesn't just happen to one person, it really happens to the family, the people who were close to you. And so by having those conversations and piecing the puzzle back together, it really came to the fore that actually, you know, hypersexuality was very, very present in it. And then there's the decisions of what to include in the film. And the good news is the film is available publicly tomorrow. So we will share a link to this, which will be on director's notes after the event, and you'll be able to watch it for free, because it's really important for us to make sure that people can watch in their own time, and then share it with anyone who they think it might help. So I will pause here just to show you the trailer, and then we'll come back to just explain, what the psychological consequences have been.
Trust was something I took for granted.
Excuse me?
Hi. Hi.
I feel like I can't do this anymore.
What happened after made it a crazy story. I didn't want anyone to restrict me. I needed to explore other things, other places. It was unsafe. It's easier to remember if I take you back to the start.
Right, so that's the condensed 30-second version of a 20-minute short film. We were really lucky to have BFI Dog Society funding as well for it. And so since then, it's been we've been trying to see how we can use the film, and this is one way to do it. So we're very pleased to do that. When it comes to hypersexuality, so in the film, I do describe similar scenes of going on apps, cheating on my partner, and also rape and sexual assault, which did happen. So what Daisy described in risk-taking really, really speaks to me, and is something that, unfortunately, as a woman, when you're taking risks in a patriarchal society, this means that the ultimate risk that you will be taking is rape and sexual assault. There's that to acknowledge. Then there's the aftermath and how you might not remember it as a coping mechanism. So it took me 5 years to say it to anyone. And so the psychological mechanisms of sexual assault and rape, and the psychological impacts of hypersexuality, because hypersexuality is very charged for women in society. Sexuality itself it's very conditioned for women. It's not okay to have too much, but you should have just enough. So it's a really fine balance, and it's still very taboo to talk about. And the way I approach shame now, considering it took me some time, and I think I'm certainly an outlier, I wouldn't expect everyone to be able to talk about it just like this. And I encourage people who can, not everyone can. And the way I look at shame and guilt, considering I come from a Catholic background, so it's also charged in that way, is trying to distance myself from it. So I will try and externalize it. One way to do this was with the film, and just look to know that I need to understand it, but it's not for me to bear it. And that realization was really important and really helpful for me, but it's still a work in progress. I'm not completely, over it, and it still always lingers. So it's a very, very important topic to talk about. And also, what's quite hard is the hurt remains for the people you did hurt in the process. And I've managed to talk to a few people who had been close to me at the time, and some I'm able to speak to them, and we've been able to mend. So it's been really, really amazing. But I know that despite all this, the hurt can remain. So it's just you're going to live with ambiguity. Well, I certainly am living with this ambiguity, but it's okay. That's life. And what you can do practically, there's a few things, and we'll be coming to those questions in the Q&A later. But what I really want to leave you with is that hypersexuality is part of a wider, bigger urge, a transgression to. It felt like you're trying to inhibit yourself from social norms. So if you're trying to do that, or if you're just doing that without thinking it, then everything is accessible to you. And what's been really helpful for me in mania in general, in managing my illness, a psychologist told me that once. He said, why don't you flirt with the extremes? And to that, I didn't really know what it meant, but it really did make sense. So flirting with the extremes means you have a support network, once you've been diagnosed, what you can do, what you can't do. Hopefully you can talk about those experiences. And flirting with the extremes means trying to ride the wave in a safe way. And we'll get to that. But why it's really important to me is because I don't have to stick to a norm. The principle of neurodiversity really, really does come to the fore here. And that means that when I have another episode, I don't say if, just because it's a lifelong illness, then it's easier to reconstruct and you can keep moving forward. So yeah, that's all I'll say. And thank you for listening.
Great, that's fantastic. Thank you, Anne. I'm sure lots of people will that will really resonate with. And it's fantastic news that Trust Me is going to be available for everybody to see. So I really urge everyone to take a look at it, because I've seen it and it's really great. So finally, Zoe Bell has been extremely patient waiting. Thank you very much, Zoe. We are, as Anne said, we're hoping to get to some questions at the end, but if you could perhaps tell us about your rape crisis services and what's available to help women in our community of people with bipolar and who've suffered from hypersexuality, who find it so hard to talk about and difficult to find any help, really. So it'd be great to hear what's on offer. So over to you, Zoe. Thanks. We can't hear you, Zoe.
How about now?
Yes, yes.
Right,
yeah.
Okay, it's the headset. Okay, apologies. So I was saying thank you so much for having me. And like I said, I'm going to start off telling you a little bit about a rape crisis centre. And although we're regional, we're down in East Kent, it's really important to remember that these centres will be in your region, and they will, nationally, there's lots of different centres for you to be able to get support. Please, may I have the next slide? Okay, so I'm going to share a narrative. This person is anonymous, and we're going to use the name Grace. Okay, so she chose the name Grace, and I'm going to share her story. Okay, and I'm going to read it from how she shared it with me. Before I was diagnosed with bipolar, I was far more interested in sex than my peers. As in secondary school, I used to masturbate every day. My friends never talked about girls doing that, so it felt weird, and I thought I was some sort of freak. I couldn't share this with anyone, and I would find myself having these urges in school, and it would be so hard to control. I regularly had sex with boys as a teenager. I remember being really scared about getting pregnant. Got called names at school, and the shame I felt was huge. I hated myself, and I would self-injure as I felt dirty. My mental health spiraled downwards. My self-loathing increased. I've been in relationships with abusive men and have been sexually assaulted and raped. I lost contact with family members as they didn't understand my behaviour. I was a teenager in the 80s and no one spoke about sexual abuse. I struggle to hold down jobs. I don't feel safe travelling on public transport anymore. I still struggle to understand that this is a symptom of bipolar. I can link it to manic phases. The trauma that I've experienced has left me feeling unlovable. I'm now getting support to help me understand. I now have a place to go where people listen and don't judge me. Understanding that my behaviour is a symptom of my bipolar, and I'm not alone, and I won't be alone, and it's a huge help. Okay, so thank you, Molly. We'll move on to the next slide. Now, that narrative is really important, and what I would say is this young woman coming to us for support, you know, being able to go to a rape crisis centre. No, we're not bipolar specialists, but we are there for her. And I think this is the important work that Bipolar UK are doing, and a rape crisis centre, to know that there are people out there that really care about you. So if we think about rape crisis centres and members of the Survivors Trust, so when you go to a centre, it's really important that you can get the service, and they are going to have standards. You know, these are people that have a vested interest in helping you. You'll have best practice. So I'm just giving you an example here of some of the standards that we hold, and many of the centres nationally will hold. Next slide, please. For example, for us, we offer specialist services, and we are a feminist organisation, and we use the term sexual violence quite a lot. We use that in a term of violation, physically and emotionally. Okay, so that's the term that we use sexual violence for. Now, if we think about specialist support, we work with people from the age of 4. Not all rape crisis centres do, but many do. And we don't just work with women, we do work with men also. Okay, next slide, please. Okay, so counselling provision. So here's a little bit of an insight. So I'm just going to pick up on the things that possibly I may have abbreviated, because I am very, sometimes, you know, you can do that and it's not helpful. So RSA, generally, if you read that and you see that on a website, that stands for rape and sexual abuse. Okay, now here, so these are the different services we offer. Now, each rape crisis centre or sexual abuse centre will offer different services, and they usually have a really good website or helpline. So do call and reach out. If you are, at the end of the day, if you've experienced these things, they're always going to be there to help you. And counselling service is mainly one of the biggest provisions within the network for rape and sexual abuse that you'll be able to access. Okay, next slide, please. Okay, so independent sexual violence advisors. Okay, now these can offer a really wide range of services. So yes, they do support within criminal justice process, but also they support holistically. What I mean by that is you could do a referral, a self-referral, to an independent sexual violence advisor, talk to them about your bipolar, talk to them about your hypersexual behaviour, and then, you know, to work with them to help you access the service provision that you need. Okay, there is many different types of independent sexual violence advisors, and you may see lots of different abbreviations. They do support, you know, and I've put here support from report to court, and as we know, that's a very long process. But they also support you if you never want to share it with anybody else, and you need that confidential support to get practical and emotional resource, but also feel held in a really non-judgmental way. Okay, next slide, please. Okay, so service provision. So this is generally, this is what we offer as a centre. So if you can look at it, it's not just about counselling, and it's not just about independent sexual violence advisory services. There's many different things that you can access. So some people just email, some people call the helplines, some people attend workshops, do groups. Some people that are training themselves might access some of our training. The thing is, it's really important to know that also, not all, but I think many like us, we have service user consultation groups. Ours is called the Kickback Group. And they really help us give genuine feedback of the service provision. So if you have experienced rape and sexual abuse, it's your opportunity to work with the network to shape future services, to really be able to share your experience of what that's like for you. And that, you know, that's invaluable. That's invaluable to anyone in our network, is to be able to have that opportunity from you. So do always have a look at that. And I think nationally there is lots of groups that you could join. Okay, next slide, please. Okay, so this is some, obviously, as a rape crisis centre, we do have some of our clients come with us and they have diagnosis of bipolar. Some do not have a diagnosis, but have bipolar symptoms, so they class themselves at the end of the day as they have bipolar, and that's how we support them. So these are some of the impacts of what people have reported to us, and I think that you've sort of probably seen quite a theme of all the speakers today. Negative impact on relationships with partners, family and friends, that's been spoken about. Also impact on professional life. So what we've seen with many of our people that come to us is quite often sometimes the difficulty managing a job, holding a job down when they're having these phases. And then recovery from a period of hypersexuality, especially in the aftermath, if they have experienced any form of rape and sexual abuse. That adds another thing. And if we think about the aftermath, all the things that have been, that have been said and shared, the consistent theme is all those things. And one, I don't know if it's been mentioned or not, and apologies if it had, but is loneliness. And what I mean by that is, this is why it's so important today as a group, we're working together. You don't have to be alone with this. You contact Bipolar UK, you reach out to your rape crisis centre. You don't have to be lonely. You don't have to hold this on your own. Okay, next slide, please. Okay, so if you are a supporter or a carer, or you have a friend, and you don't really know, and you think, oh God, I don't know how to help, I'm not a professional, just listen. One of the key things is to be kind, be there for them and don't judge them. Yeah. Also respect their autonomy. Yeah, they're not broken. They don't need you to fix them. They just need you to help them. Yeah. So that's really, really important. Next slide, please. Okay, so national support, which is really important. As Claire shared earlier, right at the very beginning, this is obviously, we've got some national services, and these are national lines, because I know we're based down in East Kent, so it's not going to be helpful for many of you listening today. So this is Rape Crisis England and Wales 24/7 support helpline. Okay, so that's the number there. If anybody wants to take a screenshot, then please do. But I do believe this is being recorded, so you can always get the data from later. Next slide, please. Okay, and also the Survivors Trust. So again, they have over 120 member organisations, and this is their helpline too. So what I mean is, nationally, if you go on either of Rape Crisis England and Wales website or the Survivors Trust, you can look, there will be a map, and you can literally put in your postcode and it will tell you where your closest centre is. Okay, so you can access that support if you have experienced rape or sexual abuse, as a symptom of your bipolar. Next slide, please. Is a wonderful thank you to you all for taking the time, because I know, it's a very difficult subject to talk about, but it's really important that we do talk about it. We're here, and this is the reason we are here. Rape and sexual abuse, unfortunately, is quite prolific in society, and we need to be there to help women that experience these. So thank you again for listening, and I really, really appreciate it. And thank you for having me on the panel.
Well, thank you, Zoe. That's fantastic. I'm sure lots of people will find that so helpful. And just before we move on to the questions, can I just check with you? Do the rape crisis centres help people who want to talk about it, but it might be like, 5 or 10 years later? It's not a crisis.
No, not at all. No. So basically, everybody, it doesn't matter if it's recent or historic. It doesn't matter how long ago it was. You get the same validation of support as if it happened yesterday.
Okay, fantastic. Well, thank you very much for that. Right, well, we have got time for some questions. So I think the first one that we've got is, perhaps Anne, you could have a look at, think about this one. How can I help? How can I keep myself safe when I'm experiencing a period of hypersexual behaviour?
Yeah, thanks, Claire. And thanks, Zoe. I think I might take you up on the offer of coming to the Rape Crisis Centre a bit later. And that was a great question I wanted to ask Claire as well. So in terms of the keeping yourself safe, so I think that I'd make a difference between physically and psychologically. So physically, I can give you one example that I took. One was to put in a coil I had to change my contraception anyway, because it was lowering the dose of my medication, which was lamotrigine. Some people might not know this, so it's always useful to know as well. I was on the pill, and then the coil, I put it in, and it was just, what I decided what was best for me in terms of preventing any unwanted pregnancy if I were to have unprotected sex, which is one possibility if you're taking risks and you're hypersexual. And then the second one would be psychological safety. So that takes some work. It's not hard. I think feminism really helped me on this, feeling empowered. Also, weirdly, living on the canal. So I live on a narrowboat, and I walk alone in the dark on the canal. The canal is dark because it's supposed to help bats be in their environment a little bit better. But you understand then that there's a lot of social construct in the feeling unsafe. And not everyone will feel that, not every woman, but for me, actually, it's been really helpful to know that this is my day-to-day. If I walk along the canal, this is where I live, and this is where other people like me, my community, live. So that's actually really safe. And then I would say that, learning to flirt with the extremes is also helpful, and then changing your relationship to sex as well. If you think it's harboring a lot of guilt for you, I think therapy would help you change your relationship to sex. I definitely changed mine, and I wouldn't want to be in a position to say, well, putting all the responsibility on women to stay safe. However, I think you can still, if you've got enough experience with the diagnosis, make sure to tell your support network if you think you're experiencing this. And if you are, then maybe you want to go out less. But if you don't want any restriction on your freedom, which I fully support as well, and I'd be more inclined to do this in my case, then yeah, maybe see if you want a different relationship to how you conceive sex, and know that it's okay to have it if it's safe as well. So you might also want to talk about it with the people you're having sex with, just to make sure that they can also keep yourself in check. It's a bit like stopping smoking, but more fun. So yeah, I'll stop there. This is my response.
Okay, thanks, Anne. We've got another question about the best way to ask a professional for help. So how can you sort of bring it up if you're talking to a professional? You know, as Arianna was saying as well, it's not something that the survey showed. It's not something that professionals themselves ask about very much, and obviously the onus is on you to bring it up with someone who perhaps you don't know very well. It's quite difficult to know how to start that conversation. I wonder, Zoe, if you've got any tips on that.
Yeah, of course. I mean, I think for the thing is, it's I think like anything within the healthcare profession, you are going to have people that are going to have the knowledge, and those are the people, but it's identifying them. So I think that actually, and it comes back to, again, feeling empowered enough to ask, when you do go to a GP or you go to a doctor or you go to a specialist centre, do you have any knowledge? I would like to speak about my hypersexual behaviour. If you don't feel comfortable doing that, then maybe have a chaperone, have an advocate. It's about what's right for you, because you do deserve, you don't deserve to have somebody that knows nothing and can't respond to you. You have the right to ask. These services and these specialisms are really, really important. And I think that if you don't feel at that present time that you're not able to ask yourself, then maybe someone from your own network could do it for you. Seek advice from Bipolar UK, maybe contact a rape crisis centre, maybe one of their advocates can support you and help you. There's lots of different ways to sort of negotiate bridging that gap. And I would be that, don't be afraid to ask for very specific help.
Great, yeah, that's good advice. Thanks, Zoe. We've got a question about research. What research is currently being done into the link between bipolar and hypersexual behaviour. Arianna, I mean, you showed us some of the research that is being done, but I mean, it's pretty sparse, isn't it?
It is, and if we don't have consistent definitions, we can't run research, can't we? And also, there's always a judgment there. There's always value. You know, even if we don't realize that, we all have unconscious biases towards this topic. So I think first we need really to have very strong objective definitions and move from there, both in terms of biological research, but also about clinical research, you know, to then implement it into clinical practice. So more people have the skills and knowledge to help people with these issues.
But we really need to make more noise about it, I think, and try and get the research community to take it seriously as an important subject, because you know, us all talking about raising awareness and helping professionals to be able to discuss it properly and everything, that's not going to happen if there isn't an evidence base for professionals, is there? There isn't going to, it's not going to be in training programs for psychiatrists or anything unless there's an evidence base, and it's virtually non-existent at the moment.
No, still, I think the training needs to address the aspect of compassion and not judgment, which it's really difficult. We all think we're not judgmental, but actually, if we think a little bit further, I think we all have a societal bias with us. So I think that would be a good point to start. You don't need research for that, right? It's just a human with another human, and I'm quite insistent about this. Also, you know, like when you reach out, we were talking about reaching out, you want to have a response with, you know, if you reach out and then you're let down, that is just horrible, horrible, horrible. So, you know, like those things can be addressed now without any research.
Yeah. Okay, great. The last one that we've got here, I thought maybe I can tackle. How can I explain to my partner that hypersexual behaviour is a symptom of bipolar? And I think really the most important thing for a partner is to be educated about the condition themselves, because if they know enough about it, then they will be able to, you know, recognize that it genuinely is a symptom of bipolar. And so obviously, you know, the perhaps the most accessible way of educating themselves is to read what they can on the Bipolar UK website. It's not a bad place to start, especially as I think it's the only place really that's got anything about hypersexuality on it. So that's not a bad place to start. But you know, to be able to tell how it relates to other symptoms of risk taking and impulsivity, and how, and you know, just to see in our surveys and everything just how prevalent it is. I mean, it is a really significant symptom of bipolar. So that certainly would help.